Tonight I am sitting down with the former manager of the Cardiac Intensive Care Unit of Renown, Nicole Bishop. She currently is the Regional Donation Manager in Reno for Donor Network West. So Nicole, for this interview, you are going to answer the following questions based on your previous position as the ICU manager, correct?
Correct. Mm-hmm.
So first I'm going to ask you a few questions regarding your perspectives of the environment of your previous workplace as a manager. But before we jump into the actual interview, would you like to tell us a little more about the department you led?
Sure. The cardiac ICU at Renown was one of the biggest ICUs. There's 5 intensive care units there. There's a neonatal, peds ICU, a Sierra trauma unit, Roseview ICU, and a cardiac ICU. So out of those 5 units, the cardiac ICU is the biggest with 38 beds. And so anytime the rest of the units were full, or we needed to keep a trauma bed open, for example, in the trauma unit, everything would overflow into cardiac ICU. It's also a very unique layout where it's a very long unit, so you don't have a visual all the time of your ICU patients. So there's also a monitor tech that monitors all the cardiac rhythms at a central station. So there's a lot of eyes on the patient. Just the nurse isn't always looking at that patient, which is challenging for an ICU nurse. They really want to see their patient, especially if they have a breathing tube and etc.
Right.
So it was a very challenging and unique unit, and a big demand to place patients in that unit.
Good to hear.
Yeah.
So first, what was your background and what were your qualifications for this job?
Well, my background is I have worked at Renown for 24 years. Almost all of that, 23 years of that, was in the pediatric department, pediatric and peds ICU. I started out as a nurse's aide back in the day, and then I was an apprentice nurse. Then I was a pediatric nurse. Then I was a peds ICU nurse. Then I was the supervisor for 14 years of that unit. And I would have probably became manager, except for my manager followed that same trail of CNA, apprentice nurse, all the way up, and she was a manager. And so we were an amazing duo in leadership. So it was almost like we were co-managing. So I got to learn from an amazing person, and we got to lead. So all that leadership experience, the cardiac ICU was going through a lot of changes, a lot of managers it's a very difficult unit, like I said, because it's so big. And they kind of reached out to me to come out of my pediatric bubble and see what I could do to manage this unit. So I felt like I came with a lot of qualifications, mostly in pediatrics, but I can apply the same leadership skills to adults, which I did.
Great. So what changes did you implement into that apartment or department?
Well, because it was a transition into a new department, it's really tough to come in there and start laying down change. Does not make people happy, doesn't create a very trusting environment. And I definitely had a trusting environment in a pediatric world, very well respected and trusted. So that's what I was really trying to create for that first year I was there, is create that trusting environment, have an open ear, an open door policy to my unit. There was a couple things that I did institute at that time, which was, it might not sound very big, but the goal is to be able to take care of your patients quickly. And being a cardiac unit, we went down on cardiac patients, MIs, or what we call as heart attacks, and we'd have to rush down, and we would take transport monitors to bring them back up to our unit from the emergency room. A lot of this equipment was sitting down on top of each other and on the floors. So I actually worked with the maintenance department, and because of my longevity there, I was able to find some really nice shelves free. They weren't being used in other units, so I was definitely keeping a mind on the budget and put those units on that shelving, which could be plugged in and monitored more easily for our daily checks, and we could get to our patients quickly. Another thing is locking down our ICU. We were the only unit not locked down, and we did recently have a shooting during that year at the facility where a couple physicians were shot. And we were, at that point, we kind of thought about safety of our patients, being a critical care unit where most people seem to kind of go to in times of trauma and frustration. So there really wasn't a way to lock down that unit at that time. So I worked with security and other departments to lock down that unit in those moments. So that was good. And then we also really just had to make some processes um, easier. So our unit clerks and our nurses' aides would help stock that 38 bed unit several times a day. And if you don't have the equipment to do your job, you can't take care of your patient. So we created a checklist and a routine of how that was going to happen so that safety was always taken care of. So again, all these things were safety focused. And then in addition to that, that was a time when we started changing how evaluations were done. So there were several evaluations that needed to be done on my employees. Raises were automatically given to employees, and then you could kind of get the paperwork in later. We had just changed that policy where if they didn't have an evaluation, they weren't going to get a raise. So of course my priorities changed and focused on getting that staff their raises. So I ended up doing several evaluations because we were actually 25 behind because the two supervisors moved on to nurse practitioner roles. So it was really a lot of maintaining the unit, daily patient care, safety, and creating that trusting environment.
Wow, so some big changes there. Was the change hard for your staff?
It was because they were thankful, but they were also guarded because they'd seen several managers leave over the years, and so they were kind of thinking, what's this manager going to be like? What is she going to do for us? Can she help out in times of need? And I really do feel a lot of it was explaining the whys. Why are we doing this? Why is this process going to be the way it is? What do I need you to do today? So a lot of these processes was to help them do their job more effectively, and that's what I kept saying. What I'm doing and the processes we're putting in, checklists and safety, is so that they can do their job more efficiently and effectively.
Great. So why are you a leader?
I love to lead people. I've taken many leadership courses, Maddie, and they say that you manage processes, which I was doing, and you lead people. So my goal is to always lead people and preferably grow some people that they can one day take your job. So if you're not effectively leading and growing for that succession plan, then you're not effectively leading. I love to lead people. I've gotten a lot of feedback from my staff that I do that well, a lot of relationships that have been built over the years that are still there, and I pride myself on making a difference every day.
Good, that's important.
Mm-hmm.
What was important to you as a leader?
Important that I can build trust, open communication to be honest with what we're doing, what we're planning to do, listening. I call it the open door policy. Anybody can come into my office at any time, talk to me about ideas, innovative ideas, problems. If you come with a problem, come with a solution. So that was very, very important. And keeping my word. If I say we're going to do something, that's how we're going to do it. Nothing's black and white, but we're going to do it together.
Good. Mm-hmm. What was the most difficult thing about leadership in health services?
Leadership in health services, and especially being in the cardiac ICU, it's not a job that you can put on the desk for the next day. Patients are coming in, they need your help, and they need it right now. So you have to find a way to find them a bed. You have to take care of the ones that are currently there. That's your priority. And the ones that are coming in, you need to get them out of the emergency rooms. You need to put them in a safe place where they can get more specific care rather than just triaged in the ER. It's challenging when you're really strapped for beds. If you're strapped for staffing, because you want to provide safe care, you also need to find a bed as well and the appropriate unit with the appropriate training. So that was a constant battle. Of the emergency room is our front door, and you got to find a way to get them where they can get the best care possible up in the unit.
Mm-hmm. So going off of that, do you think that leadership in health is different than in other industries?
Yes. Again, because it's not something that can wait. It's just like when you see the natural disasters, when there's floods and earthquakes, and it can't wait till tomorrow. It's got to be right now.
Right.
So it's any kind of time you're problem solving, it's always we might not be able to do this, but what can we do? How can we open a bed for a patient? Where can we transfer this one? So we would work collaboratively with the physicians, social worker, case coordinators, families to find out where's the best place for this patient. Are they ready for rehab? Are they ready to move to that next level of care, which takes good collaboration in all of that chaos. It's got to be organized chaos where this one's getting ambulated and walking down the hall so we can get them home just as much as you're transferring to another unit so you can receive another patient. And you might end up having your priorities change because this patient goes into a full arrest and now you have to do CPR. So your priorities change all the time, and all of them are important.
Lots of little different pieces in the hospital. Do you think that, or I'm sorry, at the end of the day, what was the most important thing to you?
The most important thing to me in my leadership role, it's interesting because my time on cardiac ICU was short, but I created some bonds with my staff. I implemented some things for safety. We were able to give very good care to the patients during that time. We collaborated. We created a very cohesive, collaborative unit. And I'm most proud of the things that we've done to individualize our care for patients. For example, there was one patient who his son died in the military, and he was going to be buried, and the father could not leave the hospital. He was too sick, but he was alert and awake, but couldn't leave. So the only way, the family came to myself and my team and said, can we bring him here? And we said, absolutely. And like they said, have you ever done that? Brought a military person here in a casket? And we said, no, but we're going to do it.
Wow.
So we brought him here. He got to see his dad and say the last goodbyes, and then he could safely be buried, and his dad would know that he saw him.
Wow.
So that was incredible, and I feel like there was several of those things that happened over the year to give very, very good care.
Good.
So.
It sounds like you did a lot for that department, so I'm sure they appreciate it.
No, thank you.
Of course. And lastly, what do you most want to be remembered for?
That I was fair, that I worked hard, that I was available when they needed me, that I always did the right thing, and that we always found a way to do it together, and that I was open, honest, and trustworthy.
Great. Well, this concludes our interview. I appreciate you spending some time with me tonight. Thank you so much, Nicole.
You're welcome, Maddie. Thank you.